Let's talk about the typical flow and drugs given during a case. Backstory, because you know I love my backstory. My program was heavily front-loaded, so we covered Pharm 1 and 2, Basics 1 and 2, before ever touching a patient. Towards the end of our second semester, right before the start of clinicals, we were drilled on induction, the flow of things, why you give certain drugs, how do you do a machine check, those types of things that you typically do day to day in clinical. I memorized them blindly, but to me, that was the first time I really thought about the drugs outside of the chapters they were separated by. So let's help mitigate that and go over the typical induction, maintenance, and reversal drugs, and just a general flow of the OR. So first, I'm going to do a general overview of what happens before, during, and after a typical case. One of my preceptors likened the flow of anesthesia to flying a plane. You have your takeoff, which would be induction. Once you get to the desired altitude, you put everything on cruise control. That would be the maintenance phase of anesthesia. And then you prepare for landing, which is when the surgeon starts to close and you have to start getting the patient back breathing and tapering down your anesthetic and preparing for the PACU. A good clue that you need to start preparing for landing is when you hear the scrubber circulators start to count their instruments. So here's a diagram summarizing the main steps of a typical general anesthetic case and what the highlights are for each one of those steps. So what does a standard case look like? Well, first thing in the morning, I go to my assigned room and I go ahead and set up the room for that day for the kinds of cases I'm going to have that day. If I'm going to have a big ortho day with lots of spinals, I'll get all my spinal kits and supplies in the room. Or if I'm having a big Da Vinci His day, I'll go ahead and get my second IV bucket along with possibly an A line, a hot line, anything else I might need that day. It's totally case dependent. Before I ever go see a patient, I make sure to do my machine check by following the instructions on whatever anesthesia machine I'm using that day. I check my suction, my O2 nitrous tanks in the back of the machine, and I make sure that I have an ambu bag in the room and drop all of my drugs for the induction of the first case and set up my airway and my drips. Then I go see my patient in pre-op to ask them about their medical history and discuss the anesthetic for the planned surgery. If you want to know the basic preoperative evaluation flow, check out my video on how to pre-op pretty much any patient. I then go back to the OR and adjust for any changes I may need to make after seeing the patient. For example, yesterday I changed my mind and I wanted to do a TIVA and an LMA for a case that I initially wanted to use an ET tube and gas for. So I placed my intubating equipment in the top drawer of the anesthesia cart, just in case. I always have backup intubating equipment whenever I choose to place an LMA as my primary airway, and I strung up my propofol drip. I went back to pre-op, I got my patient ready for the OR by untying their gown, hooking up their IV, and placing their blood pressure and pulse ox on them. I then gave them 2 milligrams of Versed and rolled them to the OR. Once we got the patient over to the OR bed, I hooked them up, their blood pressure cuff, their pulse ox, the EKG leads, in that order. This way, their blood pressure is reading while I'm hooking up the rest of the monitors, and it helps reduce the wait time before induction. Especially since sometimes the cuff has to cycle a couple of times before it gets its reading. In most cases, I try to work in my fentanyl 50 to 100 mics right before or immediately after the patient moves over. That way, the fentanyl has a couple of minutes to work. Once I've sufficiently pre-oxygenated my patient, meaning their expired oxygen concentration is about 60% dependent on patient, I may want it a little bit higher or I may be okay with it being a little bit lower depending on the patient. I induce the patient with lidocaine and propofol. Again, this is for a typical case with a typical patient. Once I have verified I can ventilate the patient, I push my paralytic. I then tape the eyes. Depending on the paralytic I choose, I may have to bag mask ventilate the patient for a couple of minutes. Make sure to not go over 20 centimeters of water while ventilating the patient on your APL valve, so you can reduce the air you introduce into their stomach. I can feel when the paralytic has set up because it becomes easier to ventilate the patient. So once I decide the patient has been adequately paralyzed, I go ahead and intubate them. I remove the stylet once I make it through the cords and inflate the cuff of the ET tube. I hook up my circuit to the ET tube and ventilate the patient to verify fog, chest rise, and end tidal CO2. It can take several breaths to see your end tidal CO2, so I go off of the feel of the bag. I want to feel a good bounce back as I bag the patient, the fog in the ET tube, and equal chest rise. Once I have verified the ET tube is where I want it, I switch the mode of the machine to the ventilation mode. I have already preset my events, so I don't have to change any settings except inspired FiO2 concentration and total flow liters per minute. I typically change it to 60% inspired FiO2 and 2 or 1.5 liters a minute, depending on what agent I use. I secure my ET tube with tape and place either an esophageal temp probe or a skin probe. I place my bear hugger on the patient and start a second IV if necessary. That summarizes a typical ET tube induction. If I were to do a TIVA, I would start my propofol drip while I was pre-oxygenating the patient instead of turning my agent on while I'm masking the patient. If I were to use an LMA instead of an ET tube, I would do everything the same except for 2 things. I would obviously not give paralytic, and I don't give fentanyl before placing an LMA. The reason being, I don't want to knock out the patient's respirations between LMA placement and incision. Typically, the patient will start breathing on incision, but I want to get them back breathing ASAP if I'm using an LMA. My reason is that if a patient is spontaneously ventilating, I'm able to do the case with an average LMA, but if the patient is apneic, my LMA has to be a lot more effective. If the patient is on the larger size and apneic, then I am going to have to use a lot more inspiratory pressure to move those lungs than if the patient is large but breathing spontaneously. So, for that reason, I do not give fentanyl until right before incision. The second reason is that I don't want to give a vasoactive drug if I don't have to. LMA placement isn't a stimulating procedure. You can usually get by with just propofol, so there is no real reason to give an opioid until right before incision. Again, this is patient dependent. If you have a young patient that's perhaps a natural redhead or they consume a lot of drugs every single day, drink a lot, smoke a lot, vape, then you might have to give them more to tolerate the placement of the LMA and the presence of the LMA before incision. So, now that the patient is ventilating, we are all situated and we're just going to maintain. Before incision, I'll give my antibiotic. I usually verify this during the timeout or once the surgeon enters the room. I'll also give them Decadron if I decide the patient will benefit from it. I'll also give them Robenal, 0.1 milligrams, to help reduce secretions, especially if I intubate the patient. This is a small enough dose to help reduce secretions and therefore reduce the chance of laryngospasm, but not a high enough dose to increase their heart rate. Depending on the situation, I might give some phenylephrine, 100 mic bolus, or start an infusion, or give ephedrine if their blood pressure and their heart rate is low. I might give them fentanyl, or switch to Dilaudid, or morphine. I might work in ketamine, or start a ketamine drip. I might add 2 grams of magnesium to that ketamine drip, not mixing the two, just simultaneously administering. Again, this is completely dependent on the patient, the type of case, the surgeon, the length of case, and if the patient received a pre-op block. I will also redose my paralytic during this time, or I can get the patient back breathing if there is no need for relaxation for this procedure. So next part. Once I notice that they have started to close, there's a couple of things that I might do. If they're paralyzed, I try to get them back breathing by starting to come down a little bit of my agent and decrease my respiratory rate in order to build up CO2. I can also switch the patient over to PSV Pro, if that is an option on your machine, and turn down the flow trigger to 0.6 to 0.8 to see if the patient has any inspiratory drive. If I anticipate it will be a quick closure and I don't have time to get the patient back breathing, I'll simply turn off my agent, leave my respiratory rate untouched, and turn my flows all the way up. I do this to get the agent off as quickly as possible. If you can get your agent off, the patient will most likely breathe. Once the agent hits around 0.4 to 0.6 expired, regardless of whether it is isoflurane or sevoflurane, I'll reverse the patient. That is, if you're using Sugammadex. If you're going to be using neostigmine and Robenal, you'll have to reverse your patient about 15 minutes, give or take, before you anticipate pulling that ET tube. So, if you have some time before wake up, 15 or more minutes, you can get your patient back breathing and lower your agent. Typically, unless the patient has a very reactive airway, like if they're a smoker or if the ET tube is very deep and close to the corona, the most stimulating thing the patient is experiencing is the presence of that ET tube. And their desire to cough and fight that ET tube kicks in somewhere around 0.8 of expired agent. usually SIVO. Because I've noticed this, I'll half my inspiratory concentration of agent to 1 if I'm using SIVO and 0.8 if I'm using ISO, and let the patient breathe off some of that agent. Once they're closing skin or applying a dressing or stapling, I'll turn off my gas, turn my flows up, the liters a minute, depends on how long this part will take, and get the gas off quicker. I check twitches, make sure the patient has 4 strong twitches with no fade. I forgot to mention that sometime during that emergence period, I will give my patient Toradol and Zofran if I feel they will benefit from it. Okay, once the dressings are applied, that is when I will give my Sugamidex, if that is a reversal I'm using. I have my total flows at 15, my FiO2 at 100, and the patient is either on a flow trigger of 2 to 3, somewhere in between those two numbers, or breathing on the bag. I remove my ET tube or LMA somewhere between 0.2 and 0 expired end-tidal agent, depending on if the patient has gone through stage 2. How do you know when it's safe to remove the ET tube? Well, starting out, you want to err on the side of caution, meaning that you want your patient to be more awake than not, so you pull the ET tube when the patient is breathing regularly, eyes are centered, and they're opening their eyes when you call their name. As you progress further in the program, you'll get more comfortable with removing the ET tube before the point of the patient opening their eyes to their name. You'll also learn about deep extubations, where you move the airway while the patient has around a full MAC of gas on board but is breathing rhythmically and regularly. To remove the tube, you deflate the cuff, you pull the ET tube and place the mask on the patient's face with your APL valve slightly closed to ensure the patient is breathing effectively and does not have anything on their cords that could prompt a laryngospasm. Once you're happy with how they look, they're breathing spontaneously and not obstructing, you can place a simple face mask on them and move them over to the bed or stretcher. Sit the head of the bed up to about 30-45 degree angle and head off to PACU. I always make sure to grab my narcotics kit, any leftover propofol, and a Neo stick. I give PACU a report consisting of any pertinent medical history, the access the patient has, and the narcotics given, and any vasoactive drugs given in the last 15 minutes, the amount of fluid, and if there were a difficult mask or airway. I chart my postoperative vitals and status and end the anesthesia time. And that's it. That's the most basic rundown of what happens for a general anesthetic case. There are so many nuances to anesthesia that it would be difficult to cover them all here. Anesthesia is a lot like cooking as opposed to baking. In baking, you have an exact list of ingredients that you have to mix in just the right ratios, otherwise the outcome doesn't work. In anesthesia is a lot more like cooking, where you add a little bit of this, a dash of that, and you add and remove and tweak as the case progresses, and as you develop more as a provider. There are a few exact, but it's an art as well as a science. So I hope this video was helpful in explaining the general flow of an anesthetic general case. That way you might feel a little bit more prepared when you show up to clinicals, and or it might help you start to piece the chapters into where they fit in what I just described. As always, please let me know what you guys like about the videos, what you don't like, what you wish for me to improve so I can continue making this channel better for you all. And as always, I hope you have a wonderful day.